welcome to another Open Hand Therapy Initiative webinar brought to you in association with the University of the Witwatersrand in Johannesburg and the South African Society of Hand Therapists. So today's webinar is about what to do with a Zone 5 flexor tendon repair. So first up, we will look at how to treat a patient who is referred on time, and then how to treat a patient who is not referred on time. And we will have a little bit of time for questions and discussions at the end. So without further ado, that's all from me. We're going to welcome our first speaker, and I will introduce her while she shares our screen. Isabel Mischke, thank you very, very much for joining us this evening. Isabel, interestingly, decided to specialize in hand and upper limb injuries after being a patient herself when she sustained a hand injury in her final year of occupational therapy studies in 2001. After completing her undergraduate degree, Isabel moved to London for a period and worked at King's College Hospital in London within hand therapy. Interestingly, she worked with a number of patients who were soldiers returning from Iraq who had sustained injuries. Isabel then returned to South Africa and started a private practice at 2 private hospitals in Pretoria, South Africa in 2004. She also completed a hand therapy master's degree. Isabel was involved in hand injury care outreaches in North Uganda between 2008 and 2010. And Isabel is passionate about sharing her expertise. She has presented hand therapy lectures to undergraduate OT students, to postgraduate students within the postgraduate hand therapy diploma at the University of Pretoria, and has had many other opportunities to lecture within hand therapy. In her free time, Isabel enjoys cycling, jogging, swimming, and spending time with her family. Isabel, thank you for giving up your time and sharing your expertise at a busy time of year. We really look forward to what you have to share with us this evening.
Thank you, Kirsty. I appreciate it. So without further ado, I'm just going to start sharing my screen. Just want to make sure that everybody can see that. Yes, wonderful. Okay, so it's my privilege to present to you tonight flexor tendon injuries in Zone 5 that was referred early. So as Kirsty mentioned, I work in a private hospital setting where we do get our referrals quite early. Let me just quickly see my slides. And when I good. So basically, we're going to go through 4 learning outcomes. First, today, I'm really passionate about just getting you at a place where you understand the basic concepts of flexor tendon rehabilitation. So basic terminology and where to start and what to look out for when you rehabilitate any kind of flexor tendon. Then know the specific challenges of Zone 5 flexor tendon injuries. Describe the early active motion protocol and understand the benefits of this protocol. And then lastly, understand the use of a protocol outline while adapting the protocol according to the patient's clinical presentation. So Zone 5 is basically the area between the proximal to the carpal tunnel and up to the musculotendinous junction. So this is a graph of what a Zone 5 area looks like, and that is what it looks like on a patient. Okay, so this is a Zone 4 and a 5 combined. And obviously, as you can see, there's a lot of skin coverage problems. There's a lot of injured structures there, soft tissue there. So often with a Zone 5 flexor tendon injury, there's a lot of structures involved. Multiple tendons, often there's nerve involvement, median and or ulnar nerves, vascular injuries, and then a lot of skin and soft tissue damage. So definitely in South Africa, we would see it as armed robberies or panga injuries. So all of us know that you really need to have a good look at that wound care as well. Good. The basic concepts that we're going to cover is active insufficiency, passive insufficiency, synergistic motion, adhesions versus tendon rupture or gapping, work of flexion, and the strength of repair. And that's basically like the building blocks or the foundation of your house. So you can treat any flexor tendon injury as long as you understand these basic concepts. So firstly, active insufficiency. That is what it looks like on the photo. So it's the diminished ability of a muscle to produce flexion or maintain a force of flexion when all the joints are in flexion. So that is why we don't prefer to splint a wrist in flexion. And I do know that in some of the rural settings, the plaster cast is still applied in flexion. But as soon as you do get your patient, try to get the wrist back into at least neutral so that the extrinsic flexors, the FTP and the FTS, can at least start moving so that they don't have active insufficiency and it's too difficult for your patient to get that flexion. Passive insufficiency is basically the exact opposite. So that is obviously why we make a dorsal blocking splint, to prevent your patient from stretching the tendons too far back and then rupturing the suture tendon. Synergistic motion is often confused with a tenodesis effect. Now, it's exactly the same movement that you do when you would do tenodesis, but it's an active activation of the synergist. So you put the wrist extensors actively extend the wrist as the extrinsic flexors flex. So you facilitate a length tension relationship between the two synergists, and the force production of the extrinsic flexors increases as you extend your wrist. And then the opposite occurs when you extend your digits and you flex your wrist. Good, so that's the picture. Then the next one is the tightrope of flexor tendon rehabilitation. If you can understand this concept, then it will really help you a lot. There's a very big tightrope or balance that we need to find between not rupturing your tendons or getting a gap at the suture sites versus not getting adhesions. So sometimes you would err towards the side of caution, but then because you're erring towards the side of caution, you get a lot of adhesions. Or otherwise, you're trying to not get adhesions, you're getting your patient to move, but then you could easily end up with a tendon rupture or a tendon gapping. And we are trying to get that sweet spot in between the two of them, where you still get an optimal functional outcome with limited adhesions, or as little adhesions as possible, but with still an intact tendon. And then lastly, work-off flexion. So work-off flexion is the energy necessary to overcome resistance to flexion. We need enough force to move the digits, but not to rupture the tendon. So that is the big question. How much is enough? So if you look at the repair technique that's currently used most by the surgeons in South Africa, it's the 4-strand and the 6-strand repair. And if you look at the force or the work-off flexion in milligrams, a strong grip or full fist is too much work-off flexion between week 1 and week 3, even up to week 4 for those repairs. However, a light active movement or half a fist would be completely adequate to get your tendons gliding and not exceed that work-off flexion that the 4- and 6-strand repair can actually take. So basically, we have had the poll on the immobilization, controlled passive motion, early active motion protocols, and then Manchester short splint. Just to mention, the Manchester short splint is usually mostly used for zone 1 and zone 2 flexor tendons because it allows synergistic motion of the wrist of 45 degrees. And in some instances, some of the protocols overseas use the Manchester short splint later on in their protocols, but for the purpose of this tool, we are going to focus on the early active motion protocol. I know a lot of you in rural settings still have to work with immobilized tendons or sometimes controlled passive motion. And then Hannarie is definitely going to cover a wonderful talk on when you get a late referral of the zone 5 flexor tendon, which is basically when the tendon was immobilized for a long time and you get the referral later. So she's definitely going to cover more of that. But as the early active motion protocol is basically the one that we're trying to move towards as much as possible, I would like to equip and educate you in that protocol so that you feel when you walk away from here tonight, you will be able to start introducing that protocol in your clinical setting, wherever you are practicing at the moment. So why? Why do we like the early active motion protocol? It increases the tensile strength of the tendon because of the active movement. There's more blood supply to the area. The tenocytes increase in the tendon, so the tensile strength of the tendon is stronger. It reduces formation of adhesions because there's a much better active tendon glide. With controlled passive motion, the tendons bunch. Because it's a passive motion, there's no pull through of the tendon because there's no active muscle contraction. Whereas here you get an active muscle contraction, so the pull of the tendon, the gliding of the tendon is much better. And then it shows improved clinical results as compared to controlled passive protocols. So the functional outcome is better. So how do we splint? How do we splint if we want to do an early active motion protocol in a zone 5 flexor tendon injury? So it's a dorsal blocking splint. I will show you the picture now. With the wrist in neutral, it could be in slight extension, but that depends on the structures involved. If you have wrist flexors that were also ruptured and resutured, or if you had nerves that were sutured under tension, then you must keep your wrist in neutral and definitely not in extension, but you don't have to put your wrist in flexion because then your work of flexion or your active insufficiency is going to be too much. Okay, then MPs at 30 to 40 degrees of flexion, IPs in extension. And this is basically what that splint looks like. So in our clinical setting, we just put a neoprene strap around the top. When the patient exercises, they remove the strap, they do the exercises, active flexion, active extension, and then we reapply the strap. So frequently asked questions about this early active motion protocol. When do we start passives? When to use place and hold exercises, especially if you come from a controlled passive motion protocol. How do you do this now? You're too afraid to start just moving. How far can you go? When do you make a full fist? And when do you add synergistic motion? Now, when to start passives, you can basically start passive movement of those fingers from day one after surgery to prevent joint stiffness, to warm up the soft tissue. But in recent years, Don Lalonde has shown that when you use place and hold exercises, you actually cause a jerking on the tendon, because what happens is you place the patient's hand in the position that you want it. And then when the patient needs to hold it there, all of a sudden, so it was a passive movement, and all of a sudden that muscle needs to contract to keep it there. And that causes a jerking or a whiplash on that tendon. And that can actually either cause rupture or gapping of your tendon, there where the tendon was sutured. So they actually proved with research that to just do a light half a fist of active movement gives enough tendon glide without gapping of the tendon. So try to avoid the place and hold exercises. You can do passives, but then once you've done the passives, don't ask your patient to keep it there. Just do passives, and then after that, tell your patient, now you can try to move yourself. Then how far can you go and when to add synergistic motion? We're going to go through that in the next slide. So research has shown that up to 3 weeks post-operatively, you should try to not make more than half a fist. You need to educate your patient that they can go halfway to a fist actively and then actively extend again. Why? Because the greater work of flexion of a full fist causes a greater risk of tendon rupture. And then try to teach your patient to initiate the movement with the DIPs to encourage gliding of both the FDP, flexor digitorum superficialis, and flexor digitorum profundus, so FDP and FTS tendons. So a nice tip or trick that you can use to educate your patients on how not to go too far and how to grade the flexion is to use 4 fingers in the first week. So you tell them to take the opposite hand and place 4 fingers in their palm. And then ask them to flex, initiating with the DIP up to the 4th finger. Tell them not to squeeze the finger, but just to touch. And then straighten it. Then the next week, you can actually lose a finger. So then there's 3 fingers. And you tell your patient to bend up to 3 fingers. The following week, up to week 3 to 4, you can flex up to 2 fingers. And then lastly, week 4, you can tell the patient to bend up to 1 finger, or 4 to 6 weeks, they can try to make a full fist inside their splint. If you see at week 5, around week 5, that the patient is struggling to actively extend, you can do 2 things. You can either put a ruler inside your dorsal blocking splint to facilitate that extension of the PIP joints to make sure that they don't form a flexion contracture, or you can also add a night gutter to allow the fingers that are starting to form a flexion contracture to be splinted in extension within your dorsal blocking splint at night. And then at week 6, you can gradually start weaning out of your splint. So we usually tell the patients from week 6 to week 8, they can still sleep with their splints and they can wear it for protection or pain management. But other than that, they must remove it for light ADL tasks, and they can start doing hook fist, straight fist, and full fist. However, if you do have a nerve component, like the ulnar nerve or the median nerve, then you would rather put your patient at week 6, and we'll cover that now, in an empty block splint and go for making a full fist rather than doing a hook fist, because then you're going to encourage the claw deformity, and you don't want to do that. And then at week 8, we're going to start with exercises against resistance and passive stretching added if necessary for another month, up to 12 weeks. And by 12 weeks, your patient can gradually start going back to normal activities, except for very vigorous sport, contact sport, gymming, things like that. They need to gradually ease into that. But at week 12, they can go back to normal activities of daily living and back to doing what they want to do. So obviously scar management is an extremely important part of managing this flexor tendon injury. Basically, you're going to get the tendon to glide. So that's your first thing. But I always educate my patients and tell them it's not enough for only the tendon to move. You also need to make the skin move, because these 2 structures need to both move so that they don't get time to get stuck to each other. I always also just tell them, remember there's a lot of layers under your skin. So you only see the scar, but under the scar, it's like super glue, and all the layers want to get stuck to each other. The fascia, the tendons, the nerve, the artery, the ligaments, everything up to where you were cut. Everything wants to get stuck to each other, and you need to make those structures glide on top of each other. So the tendon is already gliding, but we want to create friction between the skin and the underlying soft tissue through scar massage and cupping and getting that skin going from as soon as possible. So we start with scar massage while there is still a wound. We start by massaging around the scar, 5 circles in the one direction, 5 in the opposite direction, and then you move your fingers, and then you go again, 5 circles in the one direction, 5 in the opposite direction, right around the wound, so that you can just at least create some movement in the area where the scar is starting to lay down. Obviously, you don't want to make the wound bleed, because delayed wound closure causes more scarring. But you can just gradually start moving that skin. Once the wound is healed and the stitches is removed, you can start doing that scar massage right on top of your scar. You can also add silicone gel sheeting at night. You can add compression. And after week 6, you can start with silicone suction cupping, which we use in our private setting, which basically just creates space. So it's like a concertina. It just separates all of those layers from each other to create space for that tendon to glide backwards and forwards. And then obviously, you can also ask your colleague, your physiotherapist colleague, to add laser therapy. Then in terms of nerve involvement, if you do have nerve involvement with your zone 5 flexor tendon injury, obviously you need to make sure that you protect that sutured median or ulnar nerve. So at week 6, you're going to make the MP block splint. When you do the first splint, the dorsal block splint, make sure that you don't put it into extension. And you're going to add mirror box therapy and sensory stimulation. And when the nerve starts regenerating and you've got hypersensitivity in the palm, you can also add desensitization. So this is what the hand-based MP flexion splint, or the knuckle bender splint, that we also call it, looks like, to facilitate that tendon glide. Because otherwise, when you have a median or ulnar nerve lesion, you're going to get the patient that's going to go into an extrinsic flexion pattern. So it's going to be an MP hyperextension. Extrinsics are going to curl up into the palm. You actually want to get that tendons to glide all the way through. So you want to prevent a deformity from happening, and you want to allow the right biomechanics to get that flexus to glide nicely. Then, as we said, there's a tightrope between adhesions versus tendon rupture or gapping. So if all your tendons are gliding well after 3 to 4 weeks, so after you've done the 3 fingers, 2 fingers, 1 finger, and by 4 weeks you're nearly at touching the palm and everything is going well, the patient is able to extend well, the patient is able to flex well, keep doing what you've been doing. Don't try to add anything extra and think, now we need to move more, because then you might be at risk of either rupturing or gapping your tendon. So just continue with active extension, active flexion, initiating with the DIP, and then if you see you want to initiate full extension, you can block the MPs with a ruler to facilitate that full extension. But if you see you are ending up with a lot of adhesions, the patient is not getting the tendon glide, then you need to add synergistic motion at around 4 weeks, except when you've got a nerve that was sutured under tension, or when you've got a wrist flexor that was involved in the zone 5 flexor tendon. Then I would wait with the synergistic motion until week 6. But as soon as you reach week 6, it's completely safe to start doing that synergistic motion. Okay. So let me just quickly show you this case example that we saw in our practice. It was a patient with a diagnosis that came in with severed ulnar artery, a severed median and an ulnar nerve, severed all extrinsic flexors to all digits, so FTP and FTS, except the FPL, so flexor pollicis longus to the thumb, was intact. He severed the flexor carpi ulnaris and the flexor carpi radialis, but his palmaris longus was absent. So the first 2 weeks, we started with half a fist of active movement. 2 to 3 weeks, we started progressing in that active movement. And then he started making a full fist between week 4 to 6. Because he had nerves that were sutured and because he had wrist flexors, we only started with synergistic motion because he was starting to get some adhesions and he was not able to fully extend his hand at week 6. We started with the synergistic movement, we added that, and at week 8 he was able to fully open up his palm. As you can see with the little finger, there was still a little bit of a claw deformity. So we did apply an MP flexion splint just to make sure that he didn't develop a claw deformity while his nerve was regenerating. And we also started putting silicone gel sheeting and compression on that scar. As you can see, it was quite an angry scar. So in conclusion, you can do it. My husband always says, like, I don't know if you watch that movie Waterboy, so like, you can do it. You can do it. It's not difficult. You just need to just think about the structures that are involved and look at if you are getting adhesion formation or if your tendon is gliding well. If your tendon is gliding well, just keep doing what you've been doing. If you're getting adhesion formation, you can add a little bit more movement, be a little bit more aggressive. And then just remember, if you have nerve involvement, don't be too hard on yourself. Unfortunately, you will definitely expect a little bit of a poorer outcome. But if you keep on keeping on and you've got a longer rehabilitation period, you may still see those nerves coming back and still get a good outcome. So just hang in there, keep on keeping on. I'm sure this will at least help you to get a good start with the early active motion protocol, and be encouraged that you can do this. Thank you.
Isabel, thank you so much for making quite an intimidating condition feel quite approachable, and for really isolating the core concepts that we need to consider and breaking it down very simply for us. I think there's a couple of questions in the chat for you, but I'd like to now introduce Hannarie. So Isabel presented for us for when patients are referred on time after they receive surgery. And Hannarie is now going to talk a little bit about when patients are not referred on time to us. There's also another category of patients who never receive surgery, which isn't the focus of today's session. But Hannarie is going to address when patients are referred late. And I'd like to introduce Hannarie le Roux to you. She did her occupational therapy degree at Stellenbosch University and finished that in 2010. And then did her community service year, which is what we do in South Africa after we graduate, in a rural part of KwaZulu-Natal, the south of KwaZulu-Natal. After that, she took a break and did some traveling abroad in Europe, and then also some volunteer work in various countries in Africa. In 2013, Hannarie then returned to occupational therapy work and worked in various hospitals and rehabilitation units in the Western Cape. She began working at what is known as the Martin Singer Hand Unit at Groote Hospital, a very big hand surgery clinic, exactly 10 years ago. This is an incredibly busy clinic, and she's been there for a decade. She has been involved in student training on various platforms since 2013, so also for 10 years. Hannarie has a very special interest in gangs. Gangsterism is a big part of life in Cape Town, and she has an interest in how gang life affects the population that the hand clinic serves. And she has presented a number of interesting presentations on patient populations that are involved in gangsterism. Hannarie is a passionate hand therapist, and you'll be able to see a bit of that passion this evening. And she also completed her certificate in hand rehabilitation from Lund University in 2021 in Sweden. And again, it's such an honor for us to have you. Thank you for your time at this busy time of year, and we look forward to what you have to share with us this evening. Thank you, Hannarie.
Thank you, Kirsty. Wow, that is quite an introduction. Thank you for having me. I'm just quickly going to share my screen. Okay, so thank you so much for introducing me, Kirsty. I'm really honored. I'm by no means, when they made me fill in that little registration to say whether you're proficient or an expert, I was like, oh, and I had to read the description. But the last description did say that you feel you are intuitive in your hand therapy. And I think that's always been my way, but it's always been my problem, because then I have to find the research to support what I'm doing, which is probably the wrong way around. But that has always been the way I've learned. Yeah, so thank you so much. I'm going to jump into this just so that we don't waste time. It's quite a big topic. So late referrals in zone 5 flexor tendons. It is something we see a lot in government, and not necessarily in my clinic, but I see it a lot for as referrals coming from the outside. So we'll have a lot of referrals coming from the Eastern Cape and from wherever, like it doesn't matter where they come from. The patients are coming in and they're seeking help. Also, a lot of patients that were done in private here in Cape Town with surgeons that I've never heard of. And then they would come into the clinic and say, oh, I need therapy, you know, and it's been 10 months because they tried a little bit of this, a little bit of that, saw generous therapists, and then they come in like this. This is actually one patient, the picture you see there is a patient that was seen in the Eastern Cape. He's also mute. premorbidly. He's mute, so he speaks, but he is more non-verbally. And so he came in with his hand, and we were like, okay, we don't have no history, we just see this hand. So that's our context. But with us, I'm just gonna, oh, doesn't want to move. There we go. So with us, our context, I'm at the Martha Singer Hand Unit at Groote Schuur Hospital. This is little stats that we did for 3 months in the beginning of last year. There's the stats that we had, actually this year, January to March, what we saw. So if you see, look there, it's like 13% flexors, a lot of nerves, a lot of trauma in general, so about 30% trauma. And we've seen 300 new patients per month in our clinic. I'm the only OT, and because the other OTs in my team have to cover other wards and other clinics, but we help each other. And then we see about 12 flexors a month, if I have to like narrow it down on the average. And yeah, so then this is our protocol. I'm just giving you if they are, with us, they are referred on time, thank goodness. So we do the early active protocol, as Mischke said, Mischke, as Isabel said. Mischke is such a cool name. And yeah, so early active protocol. And I just want to thank Isabel. It really helps a lot that she's now given us a good overview. We pop our wrist inflection. It's not a choice, but it is for our patients because a lot of our patients are pangas and grinders and big trauma. So they lose a lot of tissue a lot of the time. So we have to put them into flexion. This is actually one of my doctors that I popped today just because there was not one flexor tendon in that clinic today, which is just ironic and Murphy's Law. And we keep them in this back slab for about 4 weeks. At these ranges, I always try to err on the side of 0 at the wrist, but I can't always get what I want. But when they do come back and they change the pop because it's manky or it's broken, then I get my part. Then I just go and ask the registrar really nicely to put it in 0. So we keep them in that pop for 4 weeks. And yes, you can't access the wrist, but I'll explain. Yeah, so it's just we've tried splinting, and with our patients and the amount of patients we see and the education, it's just easier for us to control what happens, because even our patients come in with pops broken, pops off. Now imagine what they're going to do when you give them a splint to take off. And then after 6 weeks, if it was a nerve repair. And then that little sucker stick is something we started to prevent IPJ contractures. We stick a sucker stick onto the P1. We push the finger down into MCP flexion. And then we tell the patient to extend the IPs until they touch the sucker stick. Works really well. And that's within the first 4 weeks. So that's just a little nugget. Oh, that's my doctor. So there you go. Okay, so now we're going to talk about late referrals. So it is a South African phenomenon, but don't panic. There's really no reason to panic anymore because there's no way to go from here. The patient, I mean, they can't get worse. I mean, they've now arrived at your house. You have so much time because they most likely have arrived 6 to 8 weeks. So there's no rush. I mean, the patient's late already. So don't panic. Let's just start from a side and then you work it back. I mean, you didn't cause it. You are now just the only hope that they have. Because there's no amount of, you can't do surgery right now. So you have to start conservatively. So you are the only hope. So don't panic. You just start, and it's a very systematic approach. So these are the 2 zone 5s that I would generally see coming through my door. On the left, most likely, it's the wrist is in flexion. The fingers are stuck in flexion. They're not that bad. That was a composite flexion, but they are flexed. You can't get full extension. There's possibly on this left hand, you'll possibly see an ulnar nerve on there. I don't know. I can't remember the patient, but I think because you see that atrophy on the first at the adductor pollicis in the first web space, see that atrophy, so it's most likely an ulnar nerve in there. That's unlikely to be a medial nerve. And then on the right, you have MCPs and hyperextension with a wrist flex. That is ulnar nerve, medial nerve involvement. You know it, it's done. There's no questions. Okay, the thumb is a hard giveaway, but if the fingers are hyperextended, the MCPs are hyperextended, there's an ulnar nerve, medial nerve. Now, I have no research to support this yet. I'm looking for it, and I've asked my surgeons, but I find medial nerves and ulnar nerves combined nervy. By that, I mean, it's like a cat sitting there on the couch with its tail just going. It's just so annoyed. So it's a little bit more sensitive when it comes to stretching and throwing things at it. Whereas the hand on the left, a very robust hand and a very teachable hand. I don't really have problems with that hand. It's up to the patient on that one, but it doesn't really give you a lot of curveballs. But the middle one, yeah, that median nerve, it really has a way of throwing you a little, I don't know, throwing you with lemons. And then you have to try and revert back, and it's often a 2 steps forward, 1 step back. And that's just my 2 cents. And I think I would like to know other people's things. So the outcomes for today, I think what would be my passion here, like what would be the win, is to say, when your patient walks in, is to be like, where are we? So like, where are we now? Are we 8 weeks? Are we 10 months? Where are we? And then what do we have? So do we have nerve involvement? Do we have a patient that's motivated? Do we have a guy that's already asking for a disability grant? Like, is that the first thing he wants, or does he want his hand? Does he have a job? Does he not have a job? You know, what are we going back to? Does he have family support? All those things. What do we have? And then what does the hand give us? So where do we start? So we have to now fall in somewhere in that process that Isabel just mentioned. You have to fall in. So where are you now? And then how to treat and how to enable. And I think that's the most important. Okay. And the why, I would say, is because why not? You are the only one for the job now. And then why are they complex? Their position is complex, but it's actually more because of those multiple structures. Flexor tendons, the ulnar nerve, the median nerve. Those are actually the two big bullies, and then median nerve especially, and then vascular structures, yes. And then sometimes there's even bone involvement for especially grinders and pangas, because a panga does go through multiple layers, and a panga also often is multi-level, which means they'll have a zone 2 and a zone 5, which is a big problem because you either have to repair it on 2 points, so and then they come in scarred down on 2 spots. So, and then the other thing is also often zone 5s are flexors and extensors, and we'll touch on that now because it's grinders. So grinders tend to roll around the arm. So, okay, then complications. Okay, we'll go through that. So complications, adhesions, especially in government when they are flexed. And a lot of my patients come in with wrist in 40 degrees flexion. So if you have a patient, the rural therapist will now probably be like, yes, I agree. The doctors are scared of putting tension on repair because they are generalist surgeons. So a lot of times the rural, you have a guy that's an MO in orthopedics. He's not necessarily a hand surgeon. And even if you have a upper limb surgeon or so that's like he's done a little bit of upper limb, but he's not yet an orthopod, but he's a MO. They really are trying their best, but they are scared, they are on the side of caution, and so they put them in a lot of flexion. The rule was always like 30, 60, 0 or 20, 70, 0, which means it makes 90 in total. So that was always the rule that doctors remember. And then joint stiffness is a big problem. Muscle atrophy, because remember, if you've been immobilized for so long, and not even immobilized in a pop, but you just come in there stiff with a rake hand, that rake hand has not been moving. So the muscles have technically atrophied. So they are weak. They can't generate the force to now glide. And then you have scar tissue, often multi-level scar tissue, sensory fallout and hypersensitivity, which I'll touch on quickly now. But then and then overall disuse and functional impairment. And I think that's the problem, because the patient comes in there like this. They've now coped with just doing one hand, and now to touch the hand is even it's awkward. It's like they've lost the motor to touch the hand and to just start doing rehab again. And then there's a big need for modified strategies, and that's the problem with late referrals, is you can't follow a protocol because you don't know where you are. So you have to now, and that's what makes them hard, is you have to say, okay, where am I now? What may I use? And I can't give you the answer. The answer is in this graph. And I sound like some, I don't know, fancy guru, but like the answer is in this graph, because where you are in the phase of tissue healing is what you will be allowed to do. Okay, so where are we now? You see on the map, you have to find yourself in this graph. And every patient's different. Does he smoke? Does he not smoke? Are they HIV positive? Because then they do have weaknesses. I've had a patient that was on testosterone therapy, and if you try anything on him, his tendon just ruptures. And then I go to read up, and people on testosterone therapy, they tend to rupture tendons. So go and study this and understand that there's phases of tissue, phases of tendon healing, and that's important. So this is a little guide that I got from a therapist when I just started working, and I've adapted it a little bit, but you can't take me on this. This is only a rough guide. I've put asterisks there. You cannot quote me on this, but this is what I kind of use. And I say, I protect up to 4 weeks my tendons in the back slab. Then I'll start doing actives out of the back slab, and then I'll introduce light passives, and I'll say now why. Note that if you are before 8 weeks post repair, so 0 to 8, you have certain restrictions. After 8 weeks, it's not much you can do wrong. The patient's probably so scarred down that he's got intrinsic splinting from that adhesion. So you're probably not going to do anything wrong. And then okay, that's supposed to be what do we have, not where do we have. That's the initial assessment. You now need to get a very good overall picture. So the ROM assessment, and then I'll go over those other ones. But ROM is probably a good indicator because that determines whether there's any surgical options for him anyway. And what splinting will be done is range of motion is a big thing. So I've just done a little bit here on ROM, and you'll see my writing there. But firstly, we're going to do the joints that look stiff. So IPs that look stiff, and you all are familiar with PIPJ. I wrote it there on the right. That's how I write it. So like -50/70. Passives is -30/80. So it's extension over flexion. And then functional ROM is actually my favorite. So I do joint ROM for specific joints. So if the PIP of the middle finger is stiff, but if the whole hand is stiff, I tend to go for the wrist. I measure the wrist with a normal goniometer. And then I don't use total active motion because once it gives me 171 degrees, I don't really know what it means. And then I have to go to a table and it's difficult for me. So I use distal palmar crease, and I've got I didn't put the picture in. I'm so sorry. So distal palmar crease is when you put that goniometer in the middle of your palm and it faces upright, so like a ruler. And then you ask the patient to flex. And as they flex, then you see that is a centimeter measurement. So that you measure the middle finger of the tip of the middle finger. So you'll measure the nail of the middle finger, and you basically, sorry, I've now lost my talk because I now try to, okay, I'm back. So you measure the centimeters when they flex actively to the middle finger, and it's perpendicular to the hand, and the hand is flat on the table. Well, it doesn't really matter, but then, yeah, that is your centimeters. So 3 centimeters active, and then passive is how far you push it and measure it again. Nail to table, that NTT, is basically the hand is flat on the table, and then you measure the goniometer from the table standing up, and the nail touches the goniometer. It's at 3 centimeters, and then passive is 1.5. That tells me he has a poor fist. How bad is his fist? It's a distal palmar crease of 3. Okay. But passively, is it a distal palmar crease of 0? Okay, that changes things. So then that's what I always ask therapists phoning in from the outside. Then ROM, extrinsic tightness is a very important factor to factor in because this will determine how much passive range of motion you can allow at certain joints. So you see there, I've asked her to flex her fingers, and then she has a active extension of the PIPJ on the left at -50. Okay, but once I've asked her to flex her wrist and flex her MCPJs, then I get her PIPJ to -10. That means her joint isn't stiff, her flexors are tight. Does that make sense? Okay, so here's a little video of just to what Isabel also said about the tendon gliding. So here, if you bring the MCPs, look at the slack you're getting on the tendon. And there you have the wrist drops and MCP straight, but then you still get something. So this is just, so now you have wrist and fingers. And that's quite hard because of the work of flexion. Okay, so that is basically the extrinsic tightness, and that's why we say you can maybe cheat a little bit and give a little bit of light passives at 6 weeks, because give at the wrist and then work at the joint. But that will be it depends on what you feel in the joint. So let pain guide you. So we don't want pain, we want stretch, and there's a big difference between pain and stretch. So remember, we don't want pain because the pain is the skin is telling you something, the tendon is giving you something, and if you push a structure past pain, you push them back into that first phase of the tendon healing, which is inflammation, which is not something we want, because once you go back in there, and also prolonged immobilization also has put them back in inflammation. So it's we don't want them going back there, because then you get swelling again, you get everything starting from scratch. So you want stretch and low load stretch when you're now going to work on this ROM, but you don't want pain, and you don't want to activate inflammation again. Okay, so now we are at grip strength, scar massage. You know, scar assessments, I'm not going to go through that. It's the Vancouver is great. It's a great tool to use and then to really work those scars, as Isabel also showed. But you can literally throw everything at a scar at 8 weeks. I like scar massage because I like patients touching things. Elastomopathy and silicone are great, but the problem is that my patients tend to believe in the product so much that they don't touch the scar anymore and don't move it. They just stick that thing on and leave it there. And then, yeah. And also, elastomopathy, I've learned that if you put it on too early, you actually break down the scar because it makes the scar too soft. So first do scar massage and really work on that scar before you, make the scar too soft. Functional limitations. Okay, so I'm going to go through this now. So the goals of therapy is, firstly, you want to restore a functional range of motion. Okay. If a patient comes in 10 months after a median nerve ulnar nerve flexor tendon, are we trying to get a fully functional hand? No, I'm not. I'm trying to get him functional as best I can. So you work with what you have. Then you minimize adhesions and stiffness. Adhesions, a lot of times they can't be prevented, especially when they come in late, but they can be stretched. And so I always explain to my patients, like, I want your adhesions to become a little bit like seaweed, where they move, or a boat that's anchored. It goes to the left and then it goes to the right, goes with the boat, but the boat isn't loose, but the boat is at least moving. And then enhanced tendon gliding. So that's that part, because the tendon is now gliding because the adhesion is giving him some slack. Minimize pain and inflammation. That is often, a lot of times, this is psychological, and you need to address that part. You need to educate very, very well so that the patient can minimize their pain. You cannot minimize someone's pain. They need to, okay, this is something, I'm not hurting myself, I'm actually doing good. Okay, and you need to make them understand, and I'll explain that now. Promote nerve healing and sensory recovery. Okay, and then improve hand strength and dexterity. Remember fibrin edema? That's when they have that edema that's now settled, or pitting edema. It's just settled. Remember, if it's on the dorsum, it's going to act as resistance for the volar. So you must just start working on that edema, soft manual massage, and really getting those intrinsic muscles moving if they have an ulnar nerve, so that you can get that fibrin broken down. And patients, but I think the biggest thing is patients must start touching their hand as soon as possible. Okay, so here is the therapeutic techniques. So I wrote their big 3 instructions and prioritize, because if you throw everything at them on the first session, you're going to flood their system, and they are just going to do, I don't know, this. They're going to do something that you don't want them to do. So depending on the phase of tissue healing, this is what you're going to apply. Again, phases of healing. So you have passive and active range of motion exercises, but apply that to function. There's no use in you giving him stretch, all the stretches of all the things, but they don't know why. What is it linked to? What is the problem? So I always tell my patients, we want this, and we want this, and we are here. Okay, so what are we going to work on first? And then you give them that thing to work on. I cannot go and work on the wrist and the MCPs and the IPJs. You're going to confuse them, and it is overwhelming. Hands are extremely complex. And if you think about it, if you had to explain this to your mom or to your dad, would they understand it? My mom doesn't. I tried, and it doesn't work. Okay, so you must break it down. And intelligent people struggle with this. My patients are intelligent. Some of them are not so intelligent. Some of them have done hard things to their brain that they don't have a lot of it left. But everyone can be educated. Okay, so that's no excuse. Then massage the joint and the scar. So no covering is what I would recommend once you meet the patient. They come in with those gloves on or something on. I have a rule, no covering. If you're going to cover the left hand, you better cover the right hand, because it's winter. If it's summer, no covering. It's not normal. So you're not going to cover it. You may massage it. You may touch it the whole time, but no covering. And then I want constant touch. Activities in warm water is a great game. So just washing the hand for first, if it's sensitive, then playing with a sponge in water. If they can't even grip a sponge, just washing the hand, rubbing the hand. Okay. Then gradual introduction of resisted exercises for adhesions. So that's, I'm going to explain now the putty and the condom, paper balls and vetkoek. So those are some of my favorite activities, and they are so cheap and easy, and they're readily available. I'm going to show you that now. So you can't do all of this in one session. Okay, so if you're going to do passive exercises, you may not give more than 2 or 3. Okay, you may more than that, because joint massage and active exercises, they count as exercises. That's a home program, so you have to pick the top 3 for this week or this 2 weeks that you're not going to see the patient. Warm water activities and those things are easy to incorporate into their ADLs, so it's a little bit different because you kind of just, it's nice bonuses if they do it, but the absolute musts that you need for this patient, you can only give 3. Okay, it's my rule. The adherence and compliance, so they're again 3 most important instructions. Link it to their diagnosis. The next visit, they must show you their exercises. The first thing I say, show me your exercises. If they can't find their hand and they can't find their finger, they didn't do it. They didn't do it. Don't even think, yeah, I did it. You didn't do it, because it's not, you didn't touch it. And then passive flexion for a flexor tendon. Passive flexion of the finger is a very good gauge whether a patient did it, because that's the first thing you learn when in any protocol is passively flex, and then actively flex, and then actively extend. That's the first 3 exercises you get in an early active protocol. So a passive flexion is all up to the patient. It has nothing to do with your internal structures. It's whether they did it or not. So if the passive flexion is not better than the last time, they didn't do it. There is, unless there's a fracture or something, there's no reason why it shouldn't be better. Then reevaluate your approach. Once the patient comes in and gives you exercise, then you know, okay, we're going back to the same thing, and we're not moving on until we get to that one. Be conservative in your splinting once they are already late. Throwing splints at a patient is just confusing them, and they often believe in the splint, which is not actually helpful. So, remember the difference between intrinsic and extrinsic. So make sure you treat the right thing. Are you treating the joint itself, or are you treating the flexors, or are you treating a combination? Joints, then that's joint stiffness. And then, okay, so splinting, active and passive ROM. If you have a hard end feel, or you are passively extending the joint, let's say you have an IPJ contracture because of a zone 5, or let's talk about the wrist. If your wrist is coming up and the passive range, the difference is 10 or less than 10 degrees, splinting is not going to work, because your fingers are padded and they are softer and they can generate more force than a splint. Splints cannot generate force, they merely maintain. Okay, so yes, you can have dynamic splints, but plastic is harder than your fingers. So splinting versus pop then. If you have a nice range, so you getting about 30 degrees in passive, you can explore splinting. I would go for it, but it depends on how much force is necessary to get that passive range. That will determine whether you're going to splint or whether you're going to pop. So splinting and casting in this section. Now we're looking at connective tissue and the viscoelastic nature of connective tissue. Now, the soft tissue can be stretched, and what we want is we actually want to get to a plastic deformation state. So elastic deformation is the tissue, once you take the force away, the tissue reverts back to that original length. Where plastic deformation is you've maintained it at an elongated length, and then after the force is removed, it stays there, and that's just the right. Now, how do we get there? And then the force applied, how much do I apply? I have a rule that we all know: low load, over long time. Low load, long stretch is the golden key in all the research. Low load, long stretch, because we don't want them going back to an inflammation state. Also, a low load, and it does allow the tendon to brace it, to say, "Ooh, okay, we're going." Okay, and when you put a stretch under it, and you do, but it's soft and it's no pain, it's not sounding any alarms, and it does give the tendon that time to go, "Ooh, brace yourself, we're going, okay, let's go." So that's how I understand it. And then with sleep, I always say, if you can't sleep in your splint, it's too hard, it's stretching you too much. And then your eyes, for stretches, I always say to the patient, you push until your eyes go like this. Oof, that's annoying. But you must never go, or under the table. You must always be like, ooh, that's annoying, but I can breathe through it. And then after about 5 to 7 seconds, the pain should start calming down. And after this, once they walk out of stage, they've done it 5 times, that specific passive stretch. Once they've done it 5 times, then they should be walking, it actually feels better. That is the right amount of stretch. Okay. So the total end range time, this is now that low load. How long must we keep it? So Ulrich and et al., they did a study in 2010, and I've put it in my references, where they basically say that static progressive stretch is the way to go. And it's stretched, then the tissue settles, and then you give a new level of stretch. Okay, so they speak about that. We all know that's actually the best, the gold standard. But the splinting, there's no splint that's actually superior. And Young, they did a study of a lot of different studies. They basically just evaluated studies and said the time in the splint consecutively they recommended was they gave 6 to 10. So basically they said 6 to 9 hours is a nice time. 9 to 12 hours. But I mean, a night of sleeping is actually perfect to have a splint on. And in the day then to exercise. So working on extension and stretching out the tissue, and in the day to get that tissue active. I don't do the 2 hours on, 2 hours off as we were taught, because it confuses my patients. They leave their splints at home, so they lose their splints. So I give it to them and they must put it on at night and they take it off in the morning. And then casting. Where do we bring casting? I say when it's too stubborn to splint, you cast. And that's what I explained about the 10 degrees. So casting motion to mobilize stiffness, we all know it. Judy called it. It's the good old pop. We all have pop available to us. It's nice and cheap, and it works really well. So Flowers and Listeo, they've done, they did there was a study that actually is quoted in Young, and they speak about TERT, so the total end range time. Sorry, I was supposed to write it here somewhere. Total end range time, and they compared 3 to 6 days. So they said 6 days and slightly longer is ideal. It's with pop, it's a bigger surface area. It gives that initial heat and it gives a lot of padding. It's fewer pressure points and it's a longer wear. Now, people are scared to use this. There's really no risk. You can rather just put it on lightly and you make it not too tight in the first time until you get a little bit more proficient. If the patient feels it's too tight, he just sticks his hand in a cold bucket of water and it will come off. So TERT, 5 to 7 days, especially when there's a nerve involved. I wouldn't go longer. If there's no nerve involved, you can do 2 weeks. I just took a pop off for a kid today who we left on for 2 weeks because he lives far, got 35 degrees of wrist extension. He had composite flexion. He has a flexor tendon with an ulnar nerve. He was like this, like composite flexion was like minus 25 at his wrist. And today we could get him to plus 35. So a really good result. And it was 2 weeks in a pop. He did nothing else because the patient has a really poor premorbid. He's a FAS baby. So he has really bad premorbid functioning cognitively. So where to start? So with Sims, you get a hand like that on the left. That is his hand on the right. You start with proximal stability equals distal mobility. That's how you tackle all these hands. You go for proximal, you go for the wrist. The pain, the force you apply, it must only be painful that day. And then it settles quickly. It's not really, they mustn't need pain tablets for more than a day. If they do, you've made it too tight. Okay? And that is, we're doing on proximal stability, getting the wrist into extension so that we can overcome that flexion. And then improvement at the wrist. Once you get that, you move on to the fingers. Okay. If there's a median nerve, just be careful. They tend to give you a little bit 2 steps forward, 2 steps back. I wouldn't keep them in pops. So I do about 1, 2, 3, but I would say give it a break, let them touch again, let the nerve settle. I wouldn't go straight into new Sims, but I would do it if there was no nerve involvement or if it's just an ulnar nerve. This is an ulnar nerve with a with flexor tendon. As you see there, zone 5, and there was multiple scars on that wrist for we know reasons. So this I call the panini pop. In our clinic we call it the panini pop. So how you do it is you put the wrist in full flexion, because this is extrinsic tightness. Put the wrist in full flexion, and then you pop just the hand in a little panini, like a little bread. Okay, let it harden. Then you jack up the hand, and then you pop the rest of the arm. It works really well. Patients settle. It's not so comfortable in the first session, but literally the next day they're fine, and they come back a week later. We cut it off and we do it again, and they do really well. I sometimes give a break in between so that the patients can just move, so we don't lose too much flexion. But for just the gliding, but it works really well, and we call it the panini pop. That's how I explained it to the doctors. Then our outcomes, just quick outcomes. We do 1 week, maybe a little bit more, 7 to 12 days. I don't generally try not to go over that. And our wrists, they improve by like 25 to 45 degrees extension. And sometimes we only need 2, but 1 to 3 is enough. And 2 of these patients only needed MCP relaces after, but it was because they were stuck in hyperextension and capsular tightness. And then after we've done that for patients that have tight MCPJs, I put them in a static progressive splint. So once I get the wrist where I want it, now I move on to fingers. And then you have lots of options to do with finger splinting, but I generally like this splint. It's quite a robust little splint. And the patient just has either an elastic strap on the left, or you have static straps, like on the ones on the right. Static progressives, the patient adjusts it himself. So either you have Velcro or you have that hook around the wrist, and the patient just makes a knot and it moves down, 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 get it into more flexion. Works really well. And they wear it 24/7, and I just let them take it off to do some extension, active extension, and then they go back into the splint. This is actually the boy that I splinted today. In the middle splint, the paddle splint. He actually is just an ulnar nerve with a flexor tendon, and he doesn't really need splinting, but because of his poor premorbid functioning and cognitive, like his emotional insight, I have to put him in a splint at night, because we've actually had to revert back to Sims because he got stiff. And then, but after we've now gotten them into a phase where the wrist is in a functional position, the fingers are in a functional position to start gliding. If you ulnar nerve claw, then you can do the knuckle duster or whatever is indicated. If you want to do a median nerve strap for your thumb, my patients generally don't like it, but you can put a flexion opposition strap for the thumb. I don't make the combined KDS. I just make the normal KDS. And then the function. These are my favorite activities that you'll see me using every single day. The only thing you don't get for free is the teddy dough, and you can just make your own Play-Doh. But that ball in the middle is Play-Doh that's put in a condom. Put in a condom, knot it round, knot it again. That's a great stress ball, and that's for adhesions. You need resistance to get adhesions broken down. You need resistance. And if your patient is after 8 weeks, go for it. You need to get it going. Anything you throw at them. I give them the sponge. That's one of my first ones. So the paper ball is just the Kimdras that you get in the hospital. The patient has to scrunch it with his finger without, he may not use his other hand. He may use his chest and he may use the table, but he may not use his other hand. So you must pick it up like that, everything. And they hate it, and you'll be surprised at how uncoordinated they are from all that immobilization. They get a piece of sponge. That's a piece of wheelchair cushioning that I just cut off from wheelchair cushions, that the sponges that we use. So I cut that and put it in there. And that's a condom that we get for free. And yeah, that's the and then also I make them do, like, if they bake fed cook, it's a way of getting income, and I tell them to start baking fed cook, because we want the kneading of the dough and hand washing. I make them do like all their underwear by hand. Even if they have a washing machine, I say go wash your washing by hand. And that's really getting all the functional activities into your daily living. Like, if you're going to give them a hoe grabber printed, these people waited 10 months to now get ready. They didn't think to move. You cannot give them a home program that's like a school homework. You can't do that. You need to give them functional things that make sense to them, and you link it to, if you want this, then we need to get you stretched. If you want moving, then we need to get, this is the ball, this is for getting a fist. This is the sponge, this is for getting a fist. Simple and easy. This, guys, I don't have time for this. This is the nerve. The nerve has been neglected. Go look at sensory training. Go look at Lundberg and Rose, and they give a really nice sensory training and sensibility training of phase 1, phase 2, mirror therapy, everything, how to get the brain just to activate again. And this is a great website. It's in your slides, and Helse Stavanger. It's a hospital that I visited in Norway, of friends of mine, and they started this program. It's free. It's on the website, and that's just to feel again and how to activate different parts of the brain to actually help with activating sensation in the hand. There's English videos, don't worry, but the SAT is in Norwegian. And then this is just a really cool study that they did on mice, and they cut their median nerve, and then they made them run on a treadmill. And the exercise actually, the ones that ran on the treadmill, exercise actually enhanced median nerve growth. And so guys, if you want, like, people should still go for a walkie and still exercise and not just sit at home. Then other considerations, so your combined extensors and flexors, I would say definitely discuss it with your surgeon, but we prioritize flexors over extensors. So flexors and nerves are prioritized, then extensors. But ranges you have to find with your doctor, but we generally splint them in neutral then, and like a functional position. But it depends on the repair, it depends on the tension. So speak to the surgeon. You weren't there in the surgery. If you were, you're very lucky. And then remember, this is very complex and it's a tailored approach. So be patient. There's studies, young et al., they quote the studies like they went up to 10 months of rehab once they started. And then take home message, start proximal, then move distal. Don't start at the end and now try and move it back. Start proximal, get that stability, and then go to distal mobility. Introduce one splint or casting at a time. Don't throw 2 splints at a patient. One splint, next week they can get their night splint or their day splint. One at a time. Home exercise programs, 3 exercises. 3. Choose 3. Next week you can change it if he's done well, or you can change it. There's one small goal that you need to give the patient every week. So I need you to, next time when you walk in, I'm going to touch your scar really suddenly, and I want you to be, you mustn't react. That means you did your scar massage. That's the only goal I gave them. Then next week they come in and they literally put out their hand and they go, touch it. And then I was like, good job, high five, well done. That gives them that sense of achievement, which is really important because that makes them want more. They're like, cool, let's do the rest next thing. Whereas if you give them too much, you overwhelm them and you set them up for failure, because then they're not going to achieve their goals and you don't get that sense of winning. And then integration in ADLs, that's already explained. Please integrate your exercises in ADLs. Don't give them a homework. Half my patients didn't go past like grade 9. Like today, that little boy didn't go past grade 5. He doesn't do homework, but he does do life really well. So, and then let function guide you. You are not trying to get this and beautiful gliding and everything. It's amazing when we do, but let function guide. You get the patient functional. Once he sees, oh, I can now do this. Okay, now I want more, and I want to be able to open my bottle. I want to be able to wring out my washing. Yeah, oops, that was it. Okay, so basically, you now have a square in a round hole, and you need to try and make it fit. So, I don't know. You have to chafe off the edges. Does that make sense? If you have any questions, you're welcome to ask me.
Hannarie, that was great and very Hannarie style. I love it. Thank you so much for just imparting your expertise in colorful and creative ways, and reminding us about function and how to make it the end goal and how to incorporate it into treatment. Thank you so very much. And Isabel, thank you very much for fielding the chat. I think as far as I can see, Isabel has managed to respond to all of your questions. But if you have more questions, I think Hannarie and Isabel wouldn't mind staying on for a couple of extra minutes. Just to say before we go, if you have any questions for, I think, both of our presenters or any of us at the Open Hand Therapy Initiative, you're very welcome to email us. And please also find us on Facebook and Instagram, like us, follow us, and we will be in touch early next year regarding 2025 events. Thank you, everybody. Have a good rest of the evening, and we'll see you in 2025.